Okay, 9:02. I am going to go ahead and get started. So I'd like to first thank everyone for coming and say that this is our last grand rounds before the Thanksgiving holiday. So I hope that all of you spend time with your family or your animals or the places that you really love and have a restorative break. So travel safely and enjoy your time on Thanksgiving Day. So with that, I'm about to introduce our Grand Round speaker, which is Dr. John Sheehan, MD. He is an associate professor in the Division of Hematology and Oncology here at UW School of Medicine and Public Health. So Dr. Sheehan did his medical school at University of Missouri in Columbia, and that was followed by his internal medicine residency at University of Minnesota. And after his residency, he spent 1 year doing a research fellowship in hematology at the VA in Minnesota, and then his Hem-Onc fellowship at Washington University in St. Louis. So he's been a couple different places working before he came here. He did an instructor year at Washington University and then spent quite a few years at University of Texas Health Sciences Center before joining us on faculty in 2001. So some notable things are that he's really been continually funded since 1993. I think that is fantastic. He has 2 patents. He has over 25 publications, 32 invited speakers, and has had a very impressive number of pre- and postdoc mentees in his lab. So a couple of the awards I pulled out was that he received the American Society of Hematology Scholar Award, and he is a member of the Southern Society of Clinical Investigators. So I was just asking him, what's the one thing that in your CV you are the most proud of? And what he said is really a more global statement, which is about the structure and function of 9A and that complex enzyme in the coagulation system. His expertise is obviously bleeding disorders, and he is here to talk to us about the end of hemophilia, ? So please come on up.
Thank you.
Oh. And the most important thing, which I have to thank him graciously for, is he stepped in relatively at the last minute to do grand rounds. And for any of you who've done grand rounds, you know we are in honored of this, and you will never be asked to do it again. Thank you.
Can I get that in writing?
I might be able to give you that in writing, actually. I'm willing to do that.
All right, thanks. So the rhetorical question this morning is the end of hemophilia, and I will return to that at the end. But first, my disclosures. I have recent research funding from Pfizer, and I'm currently retained as a scientific expert in patent litigation around Emicizumab, which we'll also talk about. In terms of the learning objectives, I'll start with just reviewing some of the pathophysiology and clinical features of hemophilia A and B. But I'm going to spend the majority of my time this morning talking about novel approaches to therapy, because there's been a lot of changes in a short period of time in this disease. And that will include extended half-life factors, what we call rebalancing strategies, and the bispecific antibody Emicizumab. And then finally, I'm going to end up with highlighting the evolving role of gene therapy in the treatment of hemophilia. So I can't talk about hemophilia without talking about coagulation, so you're going to have to bear with me on that. But I'm going to try to make this the least painful as I can. The sort of example I use is I think of this as a gun. And the trigger here is the injury which exposes tissue factor and forms the tissue factor 7A complex. This, in turn, activates 9A and also activates 10A. Now, if we don't get enough tissue factor exposure, in other words, if we don't squeeze hard enough on the trigger, there are inhibitors that will shut this down and nothing really happens. But if we go past the threshold, what we get is a generation of a little bit of thrombin, which primes the system. And that's not enough thrombin to really make a clot, but it is enough to activate the cofactors, most importantly factor 8 and factor 5, and generate these membrane-bound enzyme complexes. That's what the circles are, which is the intrinsic tenase complex or the hemophilia complex, which we'll be talking about today, and the prothrombinase complex. And this is the barrel of the gun, and this is the hammer, or this is the rate-limiting step for thrombin generation. So if you're missing this or you affect the activity of this complex, you affect the end result here. And just as an example of that, this is factor 9 deficient plasma without factor 9 added or with factor 9 added. And you get tissue factor exposure here, and then you get this delay and then an explosive generation of thrombin. That's what you're supposed to get. If you don't have the tenase complex, you get this sort of slower and very modest thrombin generation. So why do hemophiliacs bleed? Well, the trigger is fine, but the hammer on the barrel of the gun is not working, and so either you don't generate 9 because it's not there, or you don't have 8, and it doesn't really matter because neither one of these factors is very efficient by itself. And if you don't have that, then TFPI, or tissue factor pathway inhibitor, will shut this initiation pathway down, and antithrombin will sop up the rest, and basically you'll get a little bit of thrombin generation. The platelets work fine, so you can get sort of an initial clot, but then you don't form your solid clot, and you have delayed bleeding, which is exactly what we see in hemophilia. So it's a deficiency of the propagation phase. This is a very complex enzyme complex, and there's a very large cofactor, a set of A domains and a set of C domains that bind to the membrane. And this enzyme by itself, I like to say, can't cut butter. It's really a poor enzyme, and it's designed that way. The rate-limiting step in any metabolic pathway is highly regulated, and this enzyme is poorly reactive on its own with both substrates and inhibitors. And so that means it can persist, which is an interesting fact for thrombophilic disease, but it also allows it to move from tissue factor to activation to the platelet surface, where much of the propagation phase is occurring. So, in terms of the clinical manifestations of hemophilia, the inheritance of both of these diseases is sex-linked. Female carriers may have mild symptoms. Hemophilia A is 80% of the cases, and 50%, or basically half of them, are due to large gene inversions, which are due to structural issues in the gene. There's a pseudogene which makes that inversion more likely. The remainder of the cases are heterogeneous and may be antigen positive. These gene inversions obviously don't make any protein. And then 15 to 20% of cases are due to new mutations. For hemophilia B, that's about 20% of the cases. The genetic basis is a little different. It's primarily point mutations. That means that a lot of these hemophilia B patients make some antigen, and unsurprisingly, they have less problems with inhibitors, which we'll talk about next. And severe disease is less common. So what about the bleeding phenotype? So it's fairly, there's multiple things that go into the phenotype, but the major thing is what's the factor level. And if you have less than 1%, you have severe hemophilia, and these are the patients that bleed spontaneously into their joints. They don't need any provocation at all. If you're between 1 and 5%, you can have occasional spontaneous bleeding, and certainly prolonged bleeding after any kind of trauma or surgery. And then if you're above 5%, you're mild hemophilia, and a lot of those patients aren't picked up until they have to go to surgery or they have trauma or some kind of hemostatic challenge. So what's the type of bleeding that we see in hemophilia? Well, classically it's the joint bleed. That's over 80% of the bleeds. The other major thing is deep tissue hematomas. Intracranial hemorrhage is relatively rare, but obviously can be devastating. And mucosal bleeding is rare. That's something we see more typically with platelet defects. And so this is just an example of the classic joint bleed. You have swelling of the joint. The joint space here is still preserved, but what happens here is you have hemosiderin production, you have, or deposition, you have proliferation of the chondrocytes, you have increased in vascularity, and this is really an inflammatory arthropathy. And the end result of it is here, and then we have loss of joint space, deformity of the joint, often locked joints that are not useful. And this is the classic complications of hemophilia and what we hope to avoid with current therapy. So the mainstay of therapy has been factor replacement. And just as a historical perspective, before factor replacement, the lifespan of hemophiliacs was quite limited. I think the average patient died in the late 30s. Gradually, we evolved from whole blood infusions to plasma infusions, and then got to pooled plasma products, unfortunately, just around the time that the HIV epidemic started. And this was devastating for the hemophilia community. Between 81 and 87, there were most of the severe hemophiliacs in the country and around the world were infected with HIV or Hep C or both. And it wasn't really till probably around 92 that the blood supply was fairly deemed fairly safe. And this, like I said, is devastating to families, to the hemophilia community at large, and caused a great impetus for the development of recombinant protein products. We have since improved our viral inactivation procedures for plasma-derived factor and HIV and hepatitis C, and really the plasma products are very safe. There's always worry about new bloodborne pathogens. Zika virus would be an example of that, but so far the current procedures take care of Zika as well. But there's an interesting sidebar to this recombinant protein story, and that is shown here. And this is something you almost never see in hemophilia, which is a randomized trial, because they're very difficult to do. But this is a multinational randomized trial in what we call PUPs, or previously untreated patients. So these are all kids that are starting off on their treatment. The plasma-derived factor VIII in this study all contained von Willebrand factor, and so this is comparing different forms of recombinant factor VIII with different forms of plasma-derived VIII, and this is all of the inhibitors formed, and this is the high-titer inhibitors, which are really the problematic inhibitors. And you can see that all of this happens in the first 20 to 25 days of exposure to factor, and that the recombinant product has both more total inhibitors and more of the serious type inhibitors. So this is the SIPET study, and this has this was just published 2 years ago, and I think has been influential in terms of how we start patients on factor. So I'll just talk for a second about the problem of alloimmune inhibitors in hemophilia. So in hemophilia A, the incidence can be 30 to 35%. The major risk factor is null mutations, so mutations that don't produce any protein. And that makes sense. Additional risk factors are early exposure, the disease severity, which somewhat reflects the genotype as well. Environmental factors like, infection and inflammation. It's got the immune system revved up, and then you expose them to factor. That's not great timing. And then family history. So and that's just another a way of saying the genetic background on which that's happening. In hemophilia B, the inhibitors are much less, between 1 and 5%, probably closer to 1% in terms of serious ones. There are hypersensitivity reactions associated with benign inhibitors. The reasons for that are unclear. And there is a genotype influence here, too. You're more likely to have a deletion in your genome or in your gene rather than a point mutation if you have an inhibitor. So how do we manage the inhibitors? Well, there's two things. First, we want to treat the bleeding, and then we want to get rid of the inhibitor. So the bleeding is treated by so-called bypass agents, and FEBA has been a mainstay for many years. This acronym comes from Factor VIII bypassing activity. And really what it is a complex of factors 9, 10, 12, and 7 that also include a partial activation. It includes proteases in there, and we'll come back to that when I talk about Emicizumab. It has a lot of 7A in it, and so it allows you to trigger the initiation, to overdrive the initiation pathway to make up for the fact that you don't have the propagation of coagulation working. We also have recombinant factor 7A, which really gets used more often now. And you can use porcine factor 8, although there's a certain proportion of the inhibitors that will cross-react between the human and the pig protein. And so you have to know that. And we don't have testing for that, so we don't really use that here. So that's for treating the bleeding, and now you want to get rid of the inhibitor if you can. And so this is immune tolerance induction, and there are several protocols that are used, but generally it involves large doses of factor VIII, which means it's expensive to do. And it may be combined with immunosuppression. More recently, they've been using rituximab in some of these patients. And it's successful in about 70% of the patients. The other 30% really have a tough time. They have, patients with chronic inhibitors really have a lot of complications, a lot of bleeding. And unsurprisingly, the cost of managing inhibitor patients can easily exceed $1 million a year. So this is a big problem when it happens. So those are the really bad actors, the ones with the inhibitors, but the rest of the patients, we want to just do factor replacement. And there's two main approaches to that. One is prophylaxis, and the other is on demand. And so basically with prophylaxis, the idea is that whatever factor you're using, you're infusing 2 or 3 times a week, and the idea is to try to keep the level above 1% at all times, because as you saw before with the phenotypes, if you go from below 1% to between 1 and 5%, you've really changed the phenotype from severe to moderate. The other approach is on demand, and basically that is when a patient has pain, and pain in a hemophiliac is bleeding until proven otherwise. Then you infuse, and if it's a major bleed, we shoot for 60 to 80% levels. If it's a minor bleed, it's 20 to 40% levels. But what's become obvious over the last 20 years or so is that prophylaxis is much better than on-demand for preventing the clinical complications of hemophilia. That's both hemophilia A and B. But we have limitations, of course. Cost is a big one. IV access is another one. And then compliance, because, a lot of patients don't want to do an IV infusion 3 times a week. The burden of therapy there is fairly substantial. So this is, in terms of the impact of prophylaxis, it's pretty dramatic. MRI detected joint damage is markedly reduced. Bleeding is reduced. Intracranial hemorrhage is reduced, even though that's a rare event. And then quality of life measures are improved. And then really the bottom line here is if you start before age 4, you can prevent or you can preserve joint function to a large extent. So if prophylaxis is good, what if we don't have to do it as often? Wouldn't that be great? And that's the goal here with extended half-life factors. They require less frequent infusions, and the same goal is to maintain plasma levels above 1%. So 2 main strategies have been employed here. One is the use of site-specific pegylation that interferes with the liver clearance of these proteins. And the other is the formation of fusion proteins with albumin or the FC portion of the IgG molecule on the carboxy terminus of the proteins. The limitations here, the safety record in these extended half-life factors is predominantly in PTPs, or what we call previously treated patients. And so, as I just showed you before, these patients have all had over 50 days of exposure to factor. If they were going to develop an inhibitor, they already did it. So this is a much different population than untreated patients. There are still questions about PEG accumulation and chronic toxicity. PEG is fairly benign if you have to take, we have a lot of drugs that are modified with PEG, and if you're taking them intermittently, that's probably not a big deal. If you're taking them for the rest of your life, it might be a big deal, and so there's still concern about that. And then, of course, the bugaboo on all of these things is cost. And so this is a kind of a cartoon of what's happening with the pegylated factor. Gets infused, it binds to von Willebrand factor. Almost all factor VIII in the circulation is bound to von Willebrand factor. And the idea is that when it comes off of von Willebrand factor and it gets cleared by LRP receptors in the liver, that this pegylation will interfere with that and keep it in the circulation. The problem with that has become, which we'll see in a second, is that von Willebrand factor binding has a dominant effect on the half-life of the factor VIII molecule. When there's a hemostatic challenge, then of course that's the factor VIII is cleaved by thrombin and then dissociates, and then is used up. So we'll come back to why this has been less successful than hoped. The other approach is the fusion proteins, and this is basically adding the FC portion of the IgG molecule onto the C terminus of the factor, or albumin onto the C terminus of the factor. And the in vivo half-life of these proteins is prolonged by interaction with the neonatal FC receptor. So how does that work? So this is why IgG has such a long half-life in the blood, is that you have the IgG, it can be, if you say this is an endothelial cell, it can be endocytosed in an endocytic vessel, and then the endosome becomes acidified, And under those circumstances, the IgG binds very tightly to the neonatal Fc receptor. And then it goes through sorting in the cell, and things that are not bound are targeted to the lysosome and degraded. But if you're bound to the neonatal Fc receptor, then you can be recycled to the surface, and then when it hits the surface and gets to a physiologic pH again, then that molecule is released. And so that's what's happening with both the albumin fusion protein and the Fc, the molecules with the Fc fusion, is they're being recycled in that way. And that's why albumin has such a long half-life in the blood, too. So here's the outcomes for the factor VIII proteins. And up here we have the plasma-derived, and you see this is full-length plasma-derived VIII, and it's got von Willebrand factor in it, and it's got about 18-hour half-life. A full-length VIII that's recombinant that doesn't have von Willebrand factor in it, it's only got a 12-hour half-life, so that's the first clue there. And then some single-chain form that's B-domainless or just a B-domainless, they don't really have much impact on, and the B-domainless form, let me just say, is a regulatory domain in the middle of the factor VIII molecule that's not needed for hemostatic function. It's more of a domain that's involved in the stepwise activation of VIII, but once you get to 8A, the B domain is gone. So in a lot of these constructs, and also in the gene therapy constructs we'll talk about later, they're just totally missing the B domain. They're designed that way. And then we get down to our fusion protein. So this is the Fc fusion protein, 20, let's call it 20 hours to be charitable. Two pegylated forms at maybe 15 and 17. So they prolonged your recombinant half-life maybe 1.4 to a maximum of 1.5 times, but they're not any better than the plasma stuff with von Willebrand factor present. And so this, again, comes back to the fact that the dominant effect on factor VIII half-life is von Willebrand factor binding. So the successfulness of these particular fusion proteins has not been great. On the other hand, if we look at factor IX, this really does work. So this is plasma-derived, which is 21 hours. This is a recombinant 9, which is less. And there are some differences in post-translational modifications that probably explain this. But here are the fusion proteins. So here's the Fc fusion protein, the albumin fusion protein, and then this is the site-specific pegylation. And you get 86, 104, 93 hours. So you're getting 4 to 5 times the half-life of the recombinant 9. And so this really works for factor IX. And I think that, patients can now use these extended half-life proteins and may be infused once a week at most. And just to say that, these half-lives, they should be taken with a grain of salt. There's more individual variation than there is difference between products. So that's why there's been a big emphasis on individualized pharmacokinetics, and you figure out, well, how long does this factor stay in this person's blood, and then we dose the interval based on that. This is just, again, showing, this is from the factor IX Fc protein, and showing the pharmacokinetics and the time here, the extra time you get. This is actually 2% bar here, but you're getting all this extra time where you're above 2% or 1% here. This is the annualized bleeding rate. It's significantly reduced with this approach. The time to reach 1% levels on average was 11 days versus 5 days, so that's really a substantial effect. And then if you, and then I just told you about this, the individual variations in PK are what's really important, and individualized PKs are really the way we go. So what about other novel approaches? So there's sort of a general approach of what we call rebalancing hemostasis, or inhibiting the inhibitor. And there's a couple of things in development for this. First is a tissue factor pathway inhibitor antibody. Remember, that's the inhibitor that shuts down that initiation complex. And what this does is, if it inhibits the ability of that inhibitor to shut down that complex, then the initiation phase persists, and we can enhance thrombin generation in hemophiliac plasma that way. This antibody is undergoing phase 2 and 3 trials in both hemophilia A and B, and in both inhibitor patients and non-inhibitor patients. Also, antithrombin inhibition. So this is an antisense approach. It's reducing hepatocyte antithrombin message and, of course, protein expression. And again, you get a dose-dependent enhancement of thrombin generation in hemophilic plasma by reducing that inhibitor. This is in phase 3 trials, again, both hemophilia A and B, and inhibitor and non-inhibitor patients. Here's the big deal here: monthly sub-Q dosing. So if this works, this really changes things for patients. We can argue about whether these patients are going to be at increased risk for thrombotic events if they have breakthrough bleeding and they have to have replacement, and that's something that's going to have to be watched closely. But so far, it's looked okay. So, Emicizumab is a recently approved therapy, and this is this is now just for hemophilia A. Okay, this is a bispecific antibody. So on the surface here, you have the 10A's complex, you have factor 8, you have factor 9A, and you have the substrate 10. They come together in a very complex way, and you get factor 10 activation. The bispecific antibody, one arm is specific for 9A, one arm is specific for 10, and it brings them together and allows 10 activation. Now, given the complexity and the highly regulated nature of the intrinsic 10A's complex, when this first came out, there was a little bit of disbelief about how could this work. It's conceptually simple. We just bring the enzyme and the substrate together and they'll activate. But when you look at the reality of it, they had 200 antibodies against each component, which meant 40,000 combinations. And they screened them, and less than 0.3% enhanced activation of factor 10. And apparently this project was days away from being killed at Shigai Pharmaceuticals in Japan, and they were able to come up with enough activity, and then they went through a series of optimization steps, and an important part of that was having identical light chains, so that really, when you're trying to purify the bispecific product you want from a cell line, that makes a huge difference. And they humanized it, and there were additional mutations that enhanced activity. And so now that's undergone clinical trials, 4 clinical trials have been completed. Haven 1 was adolescent adults with inhibitors and weekly dosing. The Haven 2 was a pediatric trial in inhibitor patients. Haven 3 was an adolescent and adult trial in previously treated patients without inhibitors now. And then Haven 4 was and this was up to every 2 weeks here, dosing. And in Haven 4, this is a phase 3 open label study in which the patients were dosed Q4 weeks. These 3 have been published. This one has been presented but not published yet. And this is just to show in the inhibitor patients, and this is where it's easy to argue that this enzyme is an advantage, is in the inhibitor patients. These are groups that were episodically using bypass agents, and this is a group that gets no prophylaxis with Emicizumab. This is the Emicizumab group. And they've broken down, different types of bleeding, all bleeding, bleeding that needed treatment, spontaneous bleeding, joint bleeding, target joint bleeding, and all of them are substantially lower for the Emicizumab group. Over here were patients that were on prophylaxis with bypass agents continuously and then switched over to Emicizumab. And these patients, as you might imagine, were the worst ones. They're the high titer inhibitors, and they did extremely well with the antibody. This is from Haven 3, and this is looking at once a week dosing, twice a week dosing, or no Emicizumab. And you can see that the annualized bleeding rate drops substantially from 38, 1.3 or 1.5, and these 2 groups are essentially the same. And then this group is interesting here. This is group D. So these are patients that acted as their own control. So they were on factor VIII prophylaxis here. So they have a much lower baseline bleeding rate, but they still did significantly better on Emicizumab. So this looked good for non-inhibitor patients as well. And this is what the pharmacokinetics of it look like. You have first 4 weeks is loading doses, and then you have a steady state. And so this is weekly dosing and every other week dosing. And I can tell you that the every 4-week dosing after the load looks very similar. So this enzyme, or this antibody, bispecific antibody, had approval for hemophilia A with inhibitors in November 2017. Without inhibitors just last month, and the dosing I've already gone over. You have a loading, and then you have either weekly, biweekly, or every 4 weeks. So what could be wrong? Well, under adverse effects in the Haven 1 trial, there were about 5 or 6 patients that had either thrombotic microangiopathy or thrombosis. And so when you get thrombotic microangiopathy in a hemophiliac, you take notice. That's not something that should happen. And what it appears to be is that all of those patients got a significant amount of the FEBA for breakthrough bleeding. And remember, I told you that FEBA is a complex mixture with active proteases in it. And so what's believed to be happening is that you're adding more 9A to the system, and that bispecific antibody is enhancing the activity of that. And if patients, this was not observed in any patients that did not get FEBA. They came up with recommendations about how much FEBA you could use, but personally I wouldn't use any. I would use factor 7A. Factor 7A looks to be okay, and that again makes mechanistic sense. There is a low rate of anti-drug antibodies. Only less than 1% of them were neutralizing. Big thing you have to remember is if you're using this antibody, your ability to look at factor VIII activity or inhibitory titers through the usual assays is gone. So you have to have specialized assay to look at that. And the only other side effect that was really prominent was injection site reactions. All right, so what about gene therapy? So here's the goal in gene therapy. I think this is as succinct as you can be about it. You want to express the highest levels of factor possible using the lowest possible vector dose to minimize vector-associated immune responses or toxicity, and that includes genotoxicity. And so some of the issues are where do you target it? Most of the studies have been targeting hepatocytes. That's where factor IX is expressed. Liver sinusoidal endothelial cells would be another potential target. That's where 8 is normally expressed. Skeletal muscle has been used, and interestingly, hematopoietic stem cells are being looked at as well. Vector considerations are really important. Gene therapy has been coming for the last 20 years, and really all progress in it has been incremental, which is not surprising, but the big thing was the insertional mutagenesis that brought things to a screeching halt, and I think that was in the early 90s. So instead of insertional vectors, you can use episomal vectors, and that's what is mostly being used now. Those are non-integrating vectors. And then there's also a site-specific recombination approach where you're targeting the albumin promoter. That's at an earlier stage. So a big thing, a big factor here with vector considerations is the immune response. Because if you have an immune response to the vector, you're going to lose or potentially lose the expression of your protein of interest. That is tightly linked to vector dose. The more vector we have to use, the more likely we're going to get an immune reaction. And then there's considerations which have to do with the gene of interest, the size of the gene, which is more of a problem for factor 8 than it is for factor 9, the use of tissue-specific promoters or enhancers, and then using hyperactive variants allows you to use lower doses of vector, and that's a strategy that we'll see in the hemophilia B population, where they use the factor 9 Padua mutation, which has 7 to 8-fold in higher coagulant activity over wild type. This is just sort of so the main vector being used right now is the adeno-associated vector, and this kind of goes through a cartoon that goes through the potential problems. Anti-capsid antibodies are a problem that will neutralize, and some of those are pre-existing in the population, so that's a problem. Receptor binding is important for potency, and then when you get into cytosis, you got another look at the innate immune system here with the toll receptors. Then you can also have capsid breakdown and, of course, presentation in an MHC context to generate a T cell response. And finally, you get uncoating and you get your target gene in there, and then the ideal is that you get episomal AAV genome here that does the gene transfer. You can get integration though, and the higher doses you have, the more likely that is to happen. So this is a study by BioMarin Pharmaceuticals and that should be AAV5, and a B-domainless form of factor 8. And this is 9 patients with hemophilia A. And this is the vector doses here. This first patient got the low dose, didn't get any response. The blue is the factor 8. This line is the AST, so the hepatitis that occurs during this infection. And then down here, the green here is they started to use glucocorticoids or prednisone to downregulate this. And so the low dose, the intermediate dose, no factor 8. When they got to the high dose, these 7 patients, they started to get substantial amounts of factor 8 activity. You can see also, though, that you get a hepatitis here that gets treated. Here, this guy has a late hepatitis and actually has a decrement in his factor 8, so he goes back on prednisone at that point. We had one patient here who did poorly in terms of the hepatitis and was on prednisone for a long time. So there's challenges here still, but this was really the levels, so this is 100% factor VIII here, and you can see that we're getting levels, in the 50 to 100% level range consistently, at least on those 6 patients. And then this is the look at the annualized bleeding rate and the factor VIII use before the study and after the study, and it's, as you would expect, dramatically different. But this is the clinical payoff here. And 6 of these patients in the high-dose arm maintained factor VIII levels at greater than 50% for 1 year. So the long-term follow-up of this is going to be important, but this is really much, much better than we've done before. This is the Spark Therapeutics trial, and this is in factor IX. And again, now this is using a much lower, this is almost 2 orders of magnitude lower vector dose, and it's using a liver-specific promoter with the factor IX patoimmunogene. So this protein is 7-fold more active than wild type. And here's the expression levels. For this is for the 8 participants who didn't have a viral capsid-directed immune response, and they averaged around 33%, and this is at getting out to 1 year here, 33% factor level. So again, substantial, really clinically important changes in factor levels. And again, this is looking at the bleeding rate, this is looking at factor IX infusions, and this is looking at the total use of factor IX concentrate. This is number and this is amount. And you can see there's dramatic differences before and after the gene transfer for all of these. So this, again, these are highly clinically important changes. So we will be shortly opening up a gene therapy study here for hemophilia A patients. It'll be a phase 1-2 open label dose finding study of the BAY 2599023. Basically, this is again an AAV vector, AAV HU37 mediated gene transfer. It's a B domain deleted human factor VIII, and the primary objectives, of course, will be safety, trying to see what dose is necessary to sustain expression of the factor VIII at 6 and 12 months, and trying to look at the time course. There's a number of secondary objectives here in terms of immune responses, bleeding episodes, quality of life, and so forth. So we're fairly excited about that. We're going to have to struggle or fight for slots on that study. So the end of hemophilia, well, as they say in the Hertz commercial, not exactly. The prevalence of hemophilia is likely to remain stable or be modestly increased. And, so the number of new mutations wouldn't be expected to change. Gene therapy is not going to affect germline sex-linked transmission. However, will improved therapy lessen concerns about hemophiliac offspring, and will parents who are at risk for having a hemophiliac child, are they more likely to say, yeah, this is okay, this is something we can deal with? The other thing that I didn't really talk about today, but that is clearly happening, is the lifespan in hemophiliacs is increasing along with aging complications. And so they are not immune to developing coronary artery disease. They have a less of a mortality rate with it, probably because they're partially protected from that last clot event. But it raises a lot of interesting management problems, and whatever you do, it probably won't be evidence-based. So the second factor, I think, is the impact of these new therapies will be substantial in terms of patient outcomes and burden of disease. So I talked about before, the ability to do sub-Q dosing versus IV administration makes things a lot simpler, takes the complications of line-associated thrombosis and infections out. And in the long half-lives for these modified factors, antibodies, and antisense-based therapies will really be dramatically lower burden of treatment. And importantly, I think something we probably don't think about a lot is this is going to increase the feasibility of treatment in developing countries, because there are a lot of countries where you just can't get factor and you can't get infusions, and that's just not happening. And then in terms of gene therapy, there's some efficacy challenges, in terms of the immune response and genotoxicity concerns that persist, and I think will continue to persist for some time. But I think gene therapy is likely to become part of the mainstream treatment options. We now have over 10 years experience with AAV vectors, and so at some point that has to be the guiding, what guides us rather than theoretical constraints. And finally here, patient and family expectations will change with the new therapies. So the reduction in joint disease and disability is going to be fabulous for the patient. The next thing that happens, though, is, people are going to want to do more. And with gene therapy and maybe some of these other therapies, that's okay. Why can't my kid play soccer? I think we're going to start to cross that bridge. And then, as in many areas of medicine, but I think in these rare diseases it's even tougher, the societal and personal costs related to these therapies will be something that we'll have to deal with. So the last thing I want to end with is the comprehensive bleeding disorders program. And this is Kristen, our social worker. This is Haley, nurse clinician. For the residents, this is the person you really need to know, is Stephanie, because she will help you out with the patients. Jesse is our program manager, has become a program manager over the last couple of years. And then the physicians involved are Carol Diamond from pediatrics, Elliot, and myself. And I'm looking a little dorky there in the white coat, but I just ran down from the ward, so I'm done there. I'll take any questions.
Wouldn't it be great if one of your patients wanted to play soccer and they could?
Yeah, that's right.
So, questions from anyone in the audience? Yes.
Do you have a sense of the current cost of gene therapy in comparison to, let's assume it works for 5 years or 10 years compared to factor?
Yeah, so that's an interesting question, because we don't know how long it lasts. And then if it doesn't last, if you lose expression in 2 years or 3 years, you may not be able to get another bite at the apple because you'll have an immune response at that point. I'm a little cynical on the cost. I don't think there's anything definite yet, but I think you'll add up if it works for 5 years, they'll add up what factor costs are over 5 years, and they'll price it right there. That's generally what happens. But it's a disease where, theoretically, if we could get the cost of gene therapy down and it's effective and it's persistent in its effect, then you could have a substantial savings in terms of treatment costs.
Yes.
So with the efficacy of Emicizumab, if you have a new untreated patient who has severe factor, would you consider starting them with regular Emicizumab, or would you start them with another factor to start off with?
Yeah, so the question is, if you had a new severe hemophiliac, and given the risks of inhibitor, should we start them on Emicizumab? I think that's interesting. I think people are thinking about it maybe as an early bridge, but although the inhibitors happen early, most things in the immune system happen early. And I don't know, when you think about food allergy and everybody trying to not expose kids to things, and then later on they seem to have worse allergies sometimes. So I don't know if we'll do ourselves favors by putting off the factor VIII exposure, but we may be able to selectively, we may not have to do it when a kid is bleeding and when they're infected, or, and those are the kind of things where the immune system's revved up, and now you're giving them a neoantigen, basically, for the severe hemophiliacs, and, that's a bad, you're just increasing your chances of getting a bad inhibitor. So I think that's to be determined. I think the pediatricians are on the front lines of this in terms of all these decisions. And the other part of that, though, you can imagine you want to do IV infusion on your 1-year-old versus, and do that 3 times a week versus sub-Q every 4 weeks. I know which way my wife would go. So, I mean, and you don't have to put a port in either. So those are all things that I think are going to get worked through.
I think if the other questions can come to the front, thank you very much.
All right, thanks.
That was great, thank you.
Okay.
Really appreciate it.
All right.